Medicare risk adjustment. What is an MRA diagnosis? Lesson objective of Module 1. You will learn to differentiate Medicare risk adjustment methodology from fee-for-service methodology and understand how the patient's conditions determine reimbursements. In this module, we will cover the following topic. Definition of MRA. Definition of MRA diagnosis. Hierarchical Condition Category or HCC. Risk Adjustment Factor Score or RAF score. Importance of accurate MRA documentation. MRA is a particular payment methodology adopted by Medicare to cover the health services cost of a patient under Medicare Advantage Plan, also called Medicare Part C. Why MRA is a special methodology? The best and easy way to understand MRA is to compare it with fee-for-service methodology. With fee-for-service, the payment depends on services or procedures performed. It depends on what you did for the patient. Let's say one of your patients with no Medicare Part C comes to see you at your medical office for chest pain, and you perform those services for him. Evaluation and management services. And an electrocardiogram. To get paid for this encounter, you must document in the patient chart each service you performed along with the medical necessity. And then, your coder must submit in the claims the code of each service performed and documented. Let's say you forget to document in your notes one of the services performed, like the electrocardiogram, for example. Your coder will not submit the electrocardiogram code in the claim. That means you will not get paid for it. That is why, concerning fee-for-service, we say services not documented, services not done. But with MRA, it is different. It is not about services or procedures that you performed for your patient. With MRA, the payment depends on how sick the patient is. It depends on the patient's diseases or conditions. It is all about the diagnosis. If Mary, one of your patients with Medicare Advantage Plan, shows up at your office and at the end of the evaluation, you document in your notes the following diagnoses: chronic obstructive pulmonary disease, peripheral vascular disease, and diabetic neuropathy. How will you get reimbursed? First, you must document the diagnoses in your notes, along with the clinical indicators to support them. And then, your coder must submit in the claim the code of each diagnosis documented and supported. If the diagnosis is not supported, the documentation is considered not valid. That is why concerning MRA diagnosis, we say diagnosis not supported, does not exist. Each year, CMS sets cost benchmarks for every risk-adjusted member, based on the patient's diagnoses during the prior year. If the physician hasn't reported their patient's health information accurately or fully, the result is often benchmarks set too low and costs of care exceeding benchmarks. CMS then thinks the physician spent too much on members' care and does not recognize the value of the care provided by the physician. That is why documenting all risk adjustment diagnoses is essential. Healthcare providers who follow best practices for risk adjustment documentation and coding have a better chance of earning greater reimbursement. Keep in mind that accurate and appropriate documentation with specific coding indirectly affects patient care through reimbursement. This, in turn, affects the amount of resources available to the patient. Here's a good example. This morning, Mary visits her primary care physician, who documents diabetes but does not report Mary's neuropathy. CMS assigns a risk factor for diabetes. When combined with demographic data, Mary's annual spending benchmark is $12,000. If Mary's physician had reported both diabetes and neuropathy, CMS would have assigned a higher risk factor and a yearly spending benchmark of $20,000. Mary's actual cost of care for the year was $17,000. But since Mary's physician only reported the diabetes diagnosis, Mary's cost of care exceeded the $12,000 benchmark by $5,000. However, if both diagnoses had been reported, Mary's cost of care would have been below the $20,000 benchmark, and the physician would save $3,000. Every January 1, Medicare wipes the slate clean for all members. Everyone is considered completely healthy until diagnosis codes are reported. Therefore, physicians should see their patients at least once a year and evaluate and document all conditions related to the patient's health status annually. As we said, CMS will use the patient's disease data to determine next year's reimbursement. For example, when you forgot to document chronic obstructive pulmonary disease, your medical coder will not submit this condition in the claim. And CMS will think that the chronic obstructive pulmonary disease is resolved and no longer exist and will delete it from the patient disease data. Therefore, the reimbursement will be reduced due to the adjustment based on the patient's new disease data. To ensure you get everything covered, document all chronic conditions at least twice a year, which means at least once every 6 months from January to June and from July to December.